Във времена на несигурност се обръщаме към най-сигурното нещо, което съществува. Науката. Науката може да пребори заболяванията, да открива лечения и да побеждава пандемии. Правила го е преди, ще го направи отново. Защото когато се срещне с ново предизвикателство, науката не се отказва, тя атакува и задава въпроси, докато не намери отговорите. Това е силата на науката. Затова даваме тласък точно на науката и я развиваме. Нашите проучвания, експерти и ресурси, всички усилия са насочени към развитието на потенциални терапии и ваксини. Другите компании и академични институции правят същото. Цялата световна научна общност работи заедно, за да се справи с предизвикателствата и всички ние използваме науката, за да помогнем това да се случи. Защото ако науката спечели, печелим всички.
Good morning, dear colleagues, dear friends. Good morning, Dr. Papadopoulos. It's a great honor for me to welcome you all for this meeting. It was unbelievable how many of you showed interest in this conference. Until yesterday, we have registered around 1,500 people. Unfortunately, due to the hard times we live in, our first meeting will be online, but I hope that in the near future we will have become this meeting like a good tradition for this region, and we will have to change and have the chance to have this welcome you all in person in the next future. Now is the time to thank all of our international lecturers, also our sponsors, without whom this meeting will be not possible and to extend the planet we have now. I hope that the themes that we will interesting and will be very helpful for more of you. And also on behalf of the organizing committee, I would like to wish you to enjoy every part of our meeting. And thank you for your participation. And not in the last, I would like to excuse everyone who is not in this meeting involved as like speaker, but in the next edition, I hope that we will have the possibility to have this meeting in like tradition in our region, and to collect more of the speakers of this region to show of our audience that the knowledge and the education, the science have no border, even that we have these difficult times. Thank you.
Professor Christova, thank you very much. I would like to welcome all of you to this first Southeastern Echocardiography meeting. We feel very happy and honored that we have such participation, and we would like to thank the sponsors and the faculty that joined this first attempt of doing an echocardiography meeting in this region. In this COVID era in which we live, we should not stop the knowledge, we should keep education And of course, with these online meetings, this can be possible for the whole world. And that's why we have attendees from more than 120 countries from all continents. And we are sure that in the next years, this will be in an annual basis, and we will try to make it with physical presence. I hope you enjoy the meeting. We want you to be interactive and ask questions. There will be a lot of time, and please excuse us if we will not have the time to answer some questions of yours. So, Krasimira, we can proceed.
We can proceed now for the next introducing for the Professor Congenital, who is not available to be online live with us, but we have pre-recorded his presentation and his congratulations to our audience.
So very welcome to this first Southeastern European meeting on echocardiography. I'm Professor Cousins from Belgium, Brussels. I'm really pleased to be here, if not in presence, to be virtually there. I can only congratulate the organizer for this very nice initiative and this one-day meeting on echocardiography. Indeed, when I'm looking at the I think the program of the meeting, I think it's fantastic. I want to follow that because there is everything about echocardiography, advanced echocardiography, very trendy topic like cardio-oncology, amyloidosis, hypertrophic cardiomyopathy, top speakers. So really a great organization, and also some dedicated topic on valvular assessment, and also what is doing echo unique. You cannot use the other techniques, for example, in the cath lab, and transcatheter interventions is a very timely topic. And at the end, there will be also some hot topic that we cannot avoid about COVID. And I will myself give you a glimpse of what you can do with echocardiography. I take the opportunity also to briefly present the new members of the different committees of the board of the ACVI regarding education, membership, research, advocacy, only good people that will work with you and will work for you in the next 2 years to bring new content in the ACVI. We have also 3 new task forces, one on cost effectiveness. This is something that we cannot avoid. And we have also, so the Adult Congenital Heart Disease Task Force that will be led by Giovanni Salvo, who is one of the speakers today. And finally, the women in cardiovascular imaging, because there are some peculiarities regarding imaging in women. Finally, we will continue with the other ones, the formation, 3D dataset and standardization, regulatory affairs, focus, interventional, and also artificial intelligence. Also importantly, I want to present you an overview of all the educational offer. I think it's very important. We will bring you information for the patients now, what we call the level 0. We will also provide some level 1 modules on demand. So with the question included in the modules, so no need to go for an exam to be certified. So I can tell you this will be a very nice content for all of you. We have already, of course, the Echo on Demand, the basic Echo course in the pocket size, and we will implement that with content for your own knowledge that will be provided by the task force regarding advocacy and so on. We have already, following the course syllabi, a very nice offer regarding the level 2 and all the exams that pertains to these courses. We will also implement the knowledge module by, of course, new scientific documents, live on-demand webinars, textbook, pocket books, toolboxes, clinical case, and so on. The same for the advanced echo, what we are talking about today. And certainly also all the exams are actually available. We will also implement that with knowledge modules. And finally, this is new. And so you are quite anticipating that because we will create mini symposia, so addressing clinical topics, patient disease oriented regarding multimodality imaging, of course, but why not also to have advanced symposia on the different modalities. And that's what you did actually today. It's to talk about advanced echo, and that's fantastic. So of course, we intend to use all these assets as in a modular way in order also to permit to the people to be certified regarding multimodality imaging in such way. And we will also conduct surveys. So this is the scientific initiative committee in order to look not only at the level of the attendees or the trainees, what will happen with our content, but also at the level of the community. So saying that, I give you also a short overview about our plans regarding the Congress of the ACVI during the next 3 years. And I hope to see you there in presence very shortly. So enjoy your Congress. It's a fantastic initiative. Congratulations again to the organizer, and see you soon.
So thank you, Professor Cossins. It was a great honor of having you in this meeting. So I think we can start with our program. The first speaker of this meeting is Professor Matteo Camelli from Siena University. He's very well known in strain in speckle tracking imaging, and he will speak about left atrial strain, whether we can use it in routine practice or is it just a method that will require a few more years to be expanded more. Matteo?
Hello to everybody. Good morning to everybody. It is my great pleasure and honor to be with all of you today. My deep congratulations to Professor Krasimira Hristova and to you, Konstantinos Papadopoulos, for the great organization, for the great idea. So I will talk about left atrial strain and a useful tool in our hands. What about LA strain? LA strain is, we have an experience of 10 years about this parameter. Is a very fast parameter that could allow us to analyze the function of the left atrium. The function analyzed with the reservoir phase, conduit phase, and atrial contraction. Regarding methodologic of this measurement, we have two different techniques, one starting from the QRS wave and one starting from the P wave. And the MASCOT study that has been a great large multi-center study compared these two different techniques, and we have that this kind of measurement, the QRS wave, is slightly more feasible, more reproducible, and with a lesser time of measurement. But if you compare the data, they're very near, and the important thing is that for both techniques, we have high level of reproducibility and feasibility, and it is a very fast measurement of this parameter. What about clinical application of left atrial strain? If we have a list of it, we can start from early damage detection. If we look at these two different subjects, on the left, we have a healthy subject, and on the right, an hypertensive patient. We can see that we have the same maximum left atrial volume. You have to trust me. But we have different LA deformation, LA function. In fact, if we look to the curves, we can see that we have a reduced deformation in the patient with arterial hypertension. If we look in a population, very selected population with controls, hypertensives, diabetes, and hypertensive and diabetes, but all of these patients with normal LV ejection fraction and normal left atrial size, we can see that we have a progressive deterioration and decrease of the left atrial deformation. And so we can conclude that if we want to detect very early damage in this kind of population, we have to use these particular parameters, that is advanced and very early predictor of disease. What about diastolic function and LV filling pressures? If we look to the Rosetta Stone, we can see that starting from preserved diastolic function, going to impaired relaxation, then pseudonormal and restrictive, we can have a progressive decline of the LA strain. And in addition to that, following this very clever study where they have compared LA deformation and preload and diastolic pressure of the left ventricle and the mean wedge pressure, we have a close relation between these two parameters. So, in addition to have a power of correlation with LV filling pressures, we have even the usefulness in patients with valvular disease, in particular mitral regurgitation and atrial fibrillation. Here we have the attitude of the left atrial strain in patients with mitral regurgitation, degenerative chronic mitral regurgitation. We have that in mild mitral regurgitation, we have an increase. So we have a Frank-Starling low of even for the left atrium. So we have that the starting overload of the chronic mild mitral regurgitation provide a more an answer of the left atrial function. But after this step, we have that in moderate and severe, we have a very progressive and net decrease of the left atrial function. In the chronic severe mitral regurgitation, we have a low, very absent, almost absent left atrial deformation. In this three particular subset, if we subdivide the population between patients without paroxysmal atrial fibrillation episodes and with past paroxysmal atrial fibrillation, we can see that in all these three groups, we have significantly different attitude. And so this study was published with the help and support of the great professor Ottavio Alfieri. In fact, after multivariate analysis, global pulse was significantly and independently associated with paroxysmal atrial fibrillation. Looking at left atrial strain before mitral surgery for severe mitral regurgitation, if we follow the patient after the cardiac intervention, we can see that the left atrial deformation analyzed before the intervention is a good prognosticator of these patients. In addition, pulse is even a predictor of the functional class after surgery, of the NIA class of the subjects, and even to the entity of the gravity of the shortness dyspnea, the effort dyspnea. And so if we look to the part of the atrial fibrillation, we have this great paper of Thomas Marwick, where we can see that in patients with cryptogenetic stroke, we have that left atrial pump strain and GLS were significantly associated with the cause of atrial fibrillation. And a particular attitude is this, that left atrial strain was more useful than LV strain in patients with normal left atrial volumes. Why? While left ventricular strain was more useful than LA strain in patients with abnormal LA volumes. And the left atrial strain is very predictive of the cardioembolic risk of these patients. And so we have an incremental power of the analysis with left atrial strain regarding the cardioembolic risk of our patients. In fact, we have some evidence that we have a correlation between left atrial deformation and the left atrial appendage emptying velocity that is a marker of risk of cardioembolism. And so it is not surprising, this data, regarding that left atrial strain is a good predictor of recurrence of atrial fibrillation after cardiac ablation. For atrial fibrillation, in fact, we have that with the cutoff of less than 10%, we have a very high risk of recurrence after cardiac ablation. So why to send these kind of patients to ablation for atrial fibrillation? And what about heart failure? Regarding symptoms, this has been a great multi-center study regarding patients with stable heart failure from 8 centers. We have that included all patients with a stage more on equal to B, stage B of American Heart Association, irrespective of LV ejection fraction. And we can see that we have not very good correlation between symptoms analyzed with the Minnesota Living with Heart Failure questionnaire and left atrial volume and LV-GLS. So it is very important, even this not very good correlation, not correlation with LV ejection fraction and no correlation with E2E prime. But we can see that we have a good correlation with left atrial strain. So the left atrial strain could be a mirror of the symptoms of heart failure patients irrespective to LV function. Now, what about prognosis of our patients? We can see that in FRF, so with the reduction of the ejection fraction, we have that after multivariable analysis, including left atrial volume and LV-GLS, so it is an independent message, we have that pulse remains significantly associated with outcome in these particular sites. In particular, the higher risk was of pulse less than 12.9%. And the same attitude is even for FPEF patients, and this is even, in my view, more important. For FPEF, we have not a lot of parameters regarding the diagnosis and the prognosis, and this parameter is very good to maintain its prognostic stratification power. And with a cutoff that is slightly higher, with 31%, we can see that left atrial reservoir strain showed the best correlation with events. And I conclude with these 2 slides regarding even the future, and even the future its study. It has been started the last year. It is a prognostic multi-center study promoted by the Young of the SCVI and the Research Innovation Committee of the SCVI. And we have that is a prognostic clinical echo study to analyze if these techniques could help in the clinical management of our patients. We are doing analysis at admission and before discharge of patients admitted for heart failure, 6 months of follow-up, and to use advanced echo. 64 centers are working now on this, and we will have first data at the end of the summer, or even probably for the next Euro Echo meeting. So in conclusion, we can say that atrial strain by speckle tracking is an accurate and feasible parameter to detect atrial functional impairment. The LA strain is useful for the diagnosis of early LA involvement in several diseases, such as heart failure, atrial fibrillation, or valvular disease. So speckle tracking could be used in selected cases for the study of the left atrium as an additional tool for diagnostic and prognostic assessment. And please join EACVI, the European Association on Cardiovascular Imaging. There are a lot of young people, but not only, and a lot of science. And as you have seen by the new president, we are thinking to do great things. Thank you very much for the attention.
Thank you, Matteo. That was a great lecture. I think that we all have to learn from you for LA strain. Krasimira, do you have questions from the audience?
We have one question. I would like to introduce for this presentation to send your question during the Q&A section. And there is one question to Professor Cameli. How do you believe that LA strain can be used to threshold for surgical criteria for mitral interventions in patients with asymptomatic severe mitral regurgitation with normal ventricular size and function?
This is a great question, a great topic. In fact, we have just received the acceptance of a sort of editorial about it, because we have data regarding early damage of the mitral regurgitation. And so if we wait too much time before mitral valve surgery for some patients, we can lose some functional status, functional power of the patient after the intervention. So in these specific patients, we could start to thinking even to anticipate the intervention. Obviously, we need data regarding multi-center trial and so on, but the technology is very useful in this topic.
Can I make two comments and questions at the same time? To keep the term clinical echocardiology, for clinicians, is there any cutoff value that we can use for our patients to say that for prediction for atrial fibrillation? We saw that peak atrial longitudinal strain of 21 is the cutoff value for prognosis. For AFib, if there is any cutoff value that we can use roughly, and for your opinion about what is more predictive for atrial fibrillation, LA volume or LA strain?
Okay, two great points. Regarding the cutoff of the left atrial for the prediction of the atrial fibrillation, it is important in which kind of population, but in general, there are the 25% of cutoff to predict the onset of atrial fibrillation. And we have even cutoffs, even studied by Marta Siges and the group with Professor Brugada, regarding the cutoff of predictor of atrial fibrillation recurrence after cardiac ablation of cardioversion, and it is lower, so 12%, 15% on the, depending on the evidence. And in my view, regarding the prediction of both episodes of atrial fibrillation and of even cardioembolic events, left atrial deformation could help us even more in an independent way respect to the left atrial volume that maintain a strong diagnostic power. So in our labs, the strong suggestion is to analyze in a good way the left atria, and so to analyze not only the diameter, not only the area, but even the volume, but even the LA strain. And if you have no LA strain, please look at the function of the left atrium. To look the left atrium, not only the left ventricle, to look even the right ventricle, as you teach me. And if you have no left atrial strain, look to the minimum and maximum left atrial volume.
I have
Great.
one very short comment. Camille, do you think that it's more important to looking about the left atrial pump strain regarding the global airway strain, especially for the patient with the HFpEF?
Yeah, there is no too much evidence about it. We have the greater evidence is about left atrial reservoir strain, the global pulse, and we noted that the contraction, the atrial contraction strain is present lower levels of feasibility and reproducibility, but in a particular subset of patients could be even important. So in particular in the atrial fibrillation patients, but we have as far not too many evidence about it, and so we have to wait some other evidence.
Okay, thank you. There is no other questions in.
Krasimira, there is one question from Mahmoud Raslan. Hi, Mahmoud. If in your daily clinical practice, which patients should we measure the LA strain? Hypertensive ones, HFpEF. Which patients would have a value from the LA strain in our routine practice?
Yeah, very good question. I summarize in my lecture this aspect to send a very clinical message. I think that the main topic where the main class of patients where we have even to report the data in the report of the patient, even for the dynamic and to follow up this kind of patients could be in the early damage, so in patients that do not present other cardiac disease, so in patients with a risk factor, for example, arterial hypertension without hypertrophy, without diastolic dysfunction. If you want to detect the very early damage, try to analyze even to the left atrial strain. After that, in patients with mitral regurgitation for the assessment of the left atrial function and the clinical status of the patient. And for the atrial fibrillation patient, it is very important even after, for example, cardioversion, to know when to stop the antithrombotic agents and the anticoagulants. And so it is not very simple to decide the time. If you have a patient that with a very, without compliance left atrium, so very stiff, I think that this kind of patient, it is at high risk of recurrence and even to higher risk of embolic events. And so I have to protect this kind of patient. And even for the heart failure, as you mentioned, in particular in the HFpEF could be very useful because a patient with an heart failure, symptoms of heart failure is very difficult that he will have a normal left atrial strain. This is a very important thing.
Great, thank you very much. Krasimira, should we proceed to the next speaker?
Yes, I would like to proceed to the next speaker. If there are some other questions, I request to make the answer of the writing during the emails of the audience. So I would like to continue with our next guest speaker. This is Professor Elif Sadeh. She is the Secretary General of the European Society of Cardiovascular Imaging. I am very honored to welcome Professor Sadeh to be our next speaker and to present the topic about the Speckle tracking echocardiography for assessment of the left and right ventricle.
Thank you very much, Krasimira. And actually, I would like to, I appreciate very much this new initiative of first Southeastern European meeting on echocardiography. And I receive very nicely this initiative because the sun rise and shine from the east. And I'm more than happy to contribute. Now, speckle tracking for right ventricular and left ventricle, for the left ventricle. Actually, we learned the speckle tracking for the first time in 2004. And this new concept came from a group from Israel, from Dr. Vered's group. And this was really something quite new and helping us a lot, changing the paradigm of Doppler-based quantifications. Speckle tracking has many advantages over Doppler. I'm sorry, something has happened to my screen. I just lost my presentation.
No worries. You can start again. Take your time.
Sorry. Can you see it?
Yes. If you go to full screen again.
Is that good?
Yes.
This full screen. All right. Now, speckle tracking provides many advantages. First of all, with speckle tracking, you can directly measure the myocardial deformation by means of tracking the natural acoustic markers. You do not need anymore the Doppler equation. Therefore, speckle tracking is almost independent of the insonation angle, and it gives you the possibility to analyze all the segments. And even more of that, you can also quantify different components of myocardial deformation. This is something very important considering the complex myocardial deformation because of different layers, myocyte layers, different fibers oriented in helical way, oriented in circumferential and longitudinal way. So the myocardium as a global function actually has longitudinal deformation, circumferential deformation, it has some torsional motion, and as a result of these myofiber shortening, there is a passive thickening. So speckle tracking gives us the opportunity to study all of these. But clinically, only longitudinal strain has so far been tested again and again. We have outcome data, robust data, and reproducible data coming from longitudinal strain. This is the reason why longitudinal strain today has an application has a place for application in our clinical practice. As we are not limited by a few segments, we can analyze all the segments in the long axis view by bringing them together in a bullseye map. What we call today, we obtain the global longitudinal strain. The global longitudinal strain gives you all segmental, average segmental values, and you obtain a complete information about the left ventricular longitudinal deformation. A normal longitudinal strain should be more negative than -20%. And today we have the opportunity to quantify right ventricular longitudinal strain on the software, but the right ventricle does not lend itself to obtain data from each and every segment. What we can do today is to measure right ventricular longitudinal strain based on a 6-segment model. Global strain, not completely the way as we get from the left ventricle, global strain or free wall longitudinal strain, depending on your need, can be quantified with the same software. Now, let's talk about the clinical applications. Clinical application of left ventricular strain can be summarized regrouped in 3 main strategies. The strategy number 1 would be the pattern recognition. The second strategy is to quantify myocardial function. And the third strategy is to understand the regional function. For pattern recognition, the tool we use is to obtain the Bullseye Plot. The Bullseye Plot appearance will strongly suggest you some specific diseases such as amyloidosis or Fabry disease or hypertrophic cardiomyopathy. Let's see some examples. Here is a patient with septal hypertrophy, actually hypertrophic cardiomyopathy with mostly septal involvement, and this is the prominent bullseye plot of that ventricle. This is another hypertrophic cardiomyopathy where the hypertrophy is mainly confined to the apical regions. And again, you have a specific bullseye plot for that. Again, another example that is very helpful in our daily clinical practice. This is the one of amyloidosis, which gives you a typical apical sparing bullseye map pattern. For myocardial function quantification, you need to calculate global longitudinal strain. You need the numerical value, and that will be very useful for us to make to detect the subclinical dysfunction of the myocardium, to make the diagnosis of heart failure with preserved ejection fraction, and also to make the early diagnosis of dilated cardiomyopathy even before any clinical manifestation. This is a typical scenario that we are facing in our everyday clinical practice. A 75-year-old woman, hypertensive, diabetic, a small lady with shortness of breath. Ejection fraction is normal, that's classical. She has grade 2 diastolic dysfunction, as you can appreciate from these measurements. However, by means of global longitudinal strain, we know that heart failure with preserved ejection fraction today is not an isolated disorder of diastole. There is widespread abnormality of both systolic and diastolic function. And if you look at the GLS of this lady, it is significantly impaired. Abnormal GLS quantification is also helpful in some other clinical scenarios. For example, asymptomatic patients with severe aortic stenosis, usually they have preserved ejection fraction while longitudinal strain is significantly decreased. And does it matter clinically? Yes, it does. Impaired GLS is associated with increased risk for the progression to symptomatic stage. It is associated with the progression to intervention. These patients need intervention earlier than those who have preserved global longitudinal strain. And finally, global longitudinal strain with a cutoff of 15 has been found to be associated with poor survival. The same applies, almost the same applies to asymptomatic patients with severe aortic regurgitation. Here is a patient with severe aortic regurgitation, dilated left ventricle, preserved ejection fraction, but the GLS is severely down. And if you look at the data, you will appreciate that GLS predicts progression to aortic valve replacement in asymptomatic patients with preserved ejection fraction, but severe aortic regurgitation. And the predictive value is additive to the clinical parameters, to end systolic left ventricular volume, and to the severity of aortic regurgitation. These patients with preserved ejection fraction, asymptomatic, if they are left without aortic valve replacement, and if the GLS is worse than minus 19%, they have a significantly worse prognosis and higher risk of death as compared to those higher risk of death. So they are better served with aortic valve replacement, maybe in the near future at an earlier stage with these, based on these data. Another very important application of strain for the left ventricle is the chemotoxicity. GLS identifies myocardial dysfunction in the course of chemotherapy related cardiac dysfunction. Look at this patient with breast cancer. GLS is normal at the beginning, ejection fraction is normal at the beginning, and 3 months later after the chemotherapy, ejection fraction still seems to be preserved, but GLS is significantly decreased. So, and recently we have the data, that very important data that came out from the SACCOR trial, which clearly tells us that a surveillance strategy based on GLS rather than ejection fraction to make the decision about initiation of cardioprotective therapy will protect more patients and revert to normal ejection fraction much more than as compared to a surveillance strategy based on ejection fraction. The third strategy is to assess the regional function. For this purpose, you need to look at the strain curve shape. The strain curve shape will give an idea, a robust idea in terms of ischemia, mechanical dispersion, and dysynchrony. Here is a typical pattern of ischemic strain curve: early systolic stretch, decreased systolic strain, and significant post-systolic shortening, which is completely different than a normal pattern. That's the pattern that you should look for, not not really only the peak values. You can also set your bullseye map in predefined frames in order to get, for example, the post-systolic strain map instead of having a map of systolic strain. This may help you and assist you with a visual display, but the most important for regional function is absolutely to look at the strain behavior. For example, this patient has an infrabasal non-transmural infarction with significant post-systolic strain, but you would rather prefer seeing this strain curve behavior. The other important issue is the mechanical dysynchrony, which is obvious in patients with left bundle branch block, and the strain curve behavior will tell you the underlying pathology: septal early contraction and rebound stretch, while the free wall does a pre-stretch deformation and late contraction. This is very consistent and specific for left bundle branch block, and tells you that the patient has a high chance to respond to CRT. Another type of dysynchrony is mechanical dispersion that does not relate to any specific dysynchrony pattern, but the curves are the peaks of the curves are heterogeneously distributed throughout the cardiac cycle. This is usually due to myocardial fibrosis. And this finding has an important predictive value for ventricular arrhythmias in a number of cardiac diseases. And in a meta-analysis that was published last year, the authors showed that the predictive value of LV mechanical dispersion was even superior to that of LV ejection fraction and global strain in terms of prognosis. What about RV? If you want to use strain for right ventricular function, you cannot be confident with the pattern recognition. You cannot define any pattern because you cannot obtain a bullseye plot of the right ventricle. But you can very nicely assess abnormal longitudinal strain of the right ventricle, which will give you an idea about the subclinical dysfunction, right ventricular involvement early in the disease course. Here is an example. This is a patient early post-cardiac transplant, at the early post-cardiac transplant phase. The right ventricular ejection fraction by MR and fractional area change was preserved, but you can appreciate that the longitudinal function is obviously down, and you can quantify this with longitudinal right ventricular strain. And this is a kind of compensation with circumferential deformation, but longitudinal strain is down. It means that the right ventricle has some troubles early after heart transplantation, which is not unexpected due to residual pulmonary vascular resistance. The normal values about right ventricular strain have been published in a number of studies. The main message here is to remind that the free wall has, of course, higher strain values. Septum, women have higher longitudinal deformation. The free wall right ventricular strain should not be worse than -23%, roughly, I must say. This third strategy is also fit for the right ventricle, which is the regional function assessment. Once again, you have to look at the strain curve shape. You can define infarction or ischemia, mechanical dispersion, and dysynchrony, which is particularly important in patients with pulmonary arterial hypertension. This is a patient with ischemic disease. Here on the left side and on the right side, the patient has transmural infarction, and this is the aneurysmal or dyskinetic portion, which sticks very nicely, which corresponds very nicely to what we obtained with the strain curves. Mechanical dispersion is particularly, of course, important in patients with arrhythmogenic cardiomyopathy. This kind of dispersion is giving you an idea about the ventricular arrhythmia risk, even though this is not a criteria for making the diagnosis of arrhythmogenic cardiomyopathy. It is very important to know that even before the clinical manifestations in the subclinical phase of the disease, you can get this type of increased mechanical dispersion in patients with arrhythmogenic cardiomyopathy. And lastly, I would like to touch upon the mechanical dyssynchrony in patients with pulmonary arterial hypertension, along with decreased longitudinal strain, because this pattern of abnormal contraction is the mechanism that is responsible of left ventricular diastolic and systolic dysfunction that occurs secondary to right ventricular dysfunction in patients with pulmonary arterial hypertension, and this is a poor prognostic sign. This is a patient illustration for you before balloon pulmonary angioplasty. You can observe how longitudinal strain is down significantly and the free wall contracts very late in cardiac cycle, and after a successful balloon pulmonary angioplasty, you can nicely observe how much longitudinal strain has recovered and how nicely the curves are time aligned. Now, for ladies and gentlemen, my conclusions for you today are the followings. Speckle tracking strain is pivotal in several cardiac diseases involving left and right ventricle for differential diagnosis, for early diagnosis, for risk stratification, and prognosis. But in my opinion, the thing which is lacking is that speckle tracking strain awaits being integrated into clinical practice guidelines. And with that, I would like to finish and thank you very much for your kind attention. And if you want to learn more, please go to check out the EACVI webpage and the education link. Thank you.
Thank you, Elif, for the very nice presentation. I think there is quite a lot of questions that we have from our audience. And one of the questions I saw, where is the chat? There is the question for the Dr. Tsonev, who is actually asking about your experience about the LV strain and stress echo. And do you have experience about the correlation with the FFR studies of significant coronary stenosis?
Significant coronary stenosis and LA and left ventricular strain? Absolutely. Yes, there are many studies actually for left. But you should, if you want to use strain for your clinical practice and to be confident with it, you should take this story from the other way around. I will give you an example. You have a patient in the emergency department. The patient has chest pain and the ECG is non-diagnostic. The troponins are not elevated, but the patient has chest pain and you are suspicious because maybe the patient has some risk factors. If during the chest pain you have a completely normal global longitudinal strain, there is a very low chance for this patient to have a significant coronary artery disease, and you can defer coronary angiography until after you get more sophisticated non-invasive tests. I think this is one of the most helpful application in the clinical practice.
Semira, we are running out of time. Professor Sade, thank you very much for this presentation. It was really great. Perhaps one short answer for a question from the audience. Should we use only the free wall or the septum as well for global strain for RV?
Yeah, this is an important question. It depends on what you are expecting, what you want to measure. Certainly, septum contributes to right ventricular contraction as much as the RV free wall. But if septum is also part of the left ventricular function, so it depends on what you are measuring. If your left ventricle is severely down, and if you are interested only to your left ventricular performance, of course you cannot include the septum. But septum certainly, as much as the RV free wall does contribute to pump the blood from the RV.
Okay, perhaps in the near future, for this strain for RV, we will have something more globally evaluated for right ventricle. Thank you. Professor Christova, we will have the honor to listen for myocardial work from you for the next 15 minutes sharp.
Okay, I will try to do my best, Kostas, to
Thank you very much.
share my screen. It's visible for you?
Yes.
Okay, myocardial work, and this is actually the new type of the strain imaging. Actually, the concept of the myocardial work is not so new, and the myocardial work, it can be measured invasively in our clinical practice by hemodynamical assessment during the cardiac catheterization, and work could be calculated from invasive LV pressure volume loop, which is take account for the dynamic relationship of the myocardium, the contrast against the changing the intercardiac pressure and the left ventricular geometry through the cardiac cycles. But how is possible nowadays we measure this parameter non-invasively? This is the most important. This is the topic that I will show during my presentation. You know that the myocardial function is mainly, this is the cardiac ejection, which is the filling process, could modulate it for the myocardial motion and deformation. It's the most important, this is the fiber orientation, which is calculated the dynamic and hemodynamic of the left ventricle. And this complex the myocardial deformation actually is contributed the ejection and the filling of the left ventricle. But when we look at about these two components of the function regarding
it's 11 hours.
Intrinsic and the ventricle function, we can show that we have, this is the fiber force development, which is the depending for the myocyte shortening. We have the wall stress and the ventricular pressure, which is responsible for the regional and the global myocardial mechanics and performance, which is regarding for the that we have the measure as the stress and deformation like the strain of the ventricle. So mainly to understand this mechanics, we need to combine these two components of the ventricular function, regular and global, to have idea how it's going to measure this work, myocardial work. So the cardiac function is equal to cardiac energy, but myocardial cardiac power is the better measure of the cardiac pump function. What is the cardiac power? This in physics we know that the power is amount of energy which is transferred and converted in time, and we use it as unit watt, which is equal to 1 joule per second. On the other hand, this is the power is also is valid measure for the cardiac function is calculated as like the cardiac index multiplied to the aortic pressure. Otherwise, the cardiac power is integrated with the both pressure after load, flow, and the heart rate, and express the energy transfer from the left ventricle to the aorta. We know that nowadays the strain imaging provides additional value in our clinical routine practice. It overcomes the strength and limitation of the left ventricular ejection fraction. Actually, the echo technology for the first time in November 2019, the American Society of Echocardiography, they recognized the strain as the great diagnostic and therapeutic value for improving the patient care. The strain reflects the most fundamental property of the myocardium, which is the shortening and the lengthening. But the myocardial work provides more diagnostic information beyond that is achieved from the left ventricular ejection fraction and strain, since it's incorporated after load and provide a measure of the myocardial efficiency. So when we have the myocardial work, we have, this is the pressure, we need to have and the deformation like the distance, and this is the strain. The pioneering of this non-invasive measurement of the myocardial work, I think, is the group of the Professor Otto Smith and with Dr. Russell, that they find the novel method for assessing this left ventricular work using the pressure strain lobes during the echocardiography. For the first parameter, we need left ventricular pressure. It's non-invasive estimating of when we're using the peripheral brachial systolic blood pressure. When synchronize it and normalize it with the echocardiography derived parameters like the valvular timing events, right mitral valve closure and opening of the aortic valve. This is during the isovolumetric contraction, systolic injection and isovolumetric relaxation time. And we have the surrogate of this left ventricular pressure versus the time is integrated. The second parameter, this is the longitudinal strain that we measured during our study in the apical view from the 3, 2, or 4 chamber view. And we need this area to combine non-invasively with the left ventricular pressure strain in millimeter mercurium per percent, and have been validated and correlated with invasive myocardial work in our practice. So we recognize some myocardial work indices. This is the global work index. This is the total work from the mitral valve closure to mitral valve opening. Global constructive work. This is the total work contributing to the pump function of the heart. Global wasted work like elongation during the systole and shortening against in the closed aortic valve, and global work efficiency, which is the fraction of the constructive work to the total work, like is the 0%. This is actually the process that we have during our machine. Is we have this is the 3-chamber view. We have this longitudinal strain with the blue eyes that we have on the Speckle tracking. For the next level, we need to have the blood pressure of our patient to input in the system. And then we derive this, calculate this global work indices as the parameter and that we need to analyze the work. So for the clinical implementation, to measure the blood pressure is very important. To have the strain from this longitudinal strain for these three views of the apical estimated. Then we have the timing of the mitral and the aortic valve events from the 2D echo and the Doppler velocity, and to analyze the left ventricular pressure curve in the constructive by adjusting the standard curve according to the valve events and the curve pressure. So this is the one of the last study for this group. This is correlated the normal value for the global work on the strain and the pressure, and in the patient with the cardiomyopathy also, and to look at about the segmental work in the patient with the left bundle and the branch broke, and responsibility for the CRT. This is most important. Actually, the work differences of the septal and the lateral valve to the left ventricle is more important, and when we have the more work differences, these patients could be more responsible for the CRT than the other patient. This is one of the first study in animal models regarding to the myocardial work, which is related to the metabolism of the heart. We look at about different clinical conditions, especially the ischemia is most provocative about the changes of the myocardial work. We have the difference of the basal and anterior valve, also posterior segments, which is injured for this a different type of dyschemia. Actually, provocated left bundle branch block is another group of the analyzing from this study, and this is more important regarding to the non-invasive assessment in the practice. So actually, left ventricle mechanics is more important non-invasive assessment of the myocardial workings to identify acute coronary occlusion in the patient with the non-STEMI acute myocardial infarction. So when we have this strain, which is very close to the zero for in the group where is the acute ischemia, when we look at the blood pressure, also we can see the differences about the normal volume and the normal the difference of the ischemic part. So the early systolic lengthening, this is the one of the most important injury that we could analyze during analyzing the myocardial work. When we have this reduced myocardial work, increasing the vascular work, decreasing the cardiac efficiencies. Also, we have the reduced end systolic strain, which is idea to represent it with the reduced myocardial work, decreased cardiac efficiency, and post-systolic shortening, which is presented with increased vascular work and decreased cardiac efficiency. So myocardial work indices was be able to account in the influence of the systolic blood pressure and the regional contraction. We therefore propose that myocardial work indices may serve as important clinical tool for selecting the patients in need for the prompt invasive treatment during the acute ischemia. The LBB is the strain hallmark for the cardiac efficiency. We have the early activation of the septum and lengthening of the septum during the systole, which is reflected for the reduced myocardial work and decreased cardiac efficiency. We have the hyperkinetic free wall, which is increased the cardiac work. So this is the imaging that we could collect for the patients for the LBP before sent to CRT, and when we send the patient for the CRT, most significant improvement of the loop for the myocardial valve of the middle septum and the middle lateral valve when they compare with the other images. This is the one of the study that we have from the normal patients collected from the Echocardiography study and non-invasive assessment of myocardial work indices. So with the normal systolic pressure and normal peak systolic strain minus 21%, we expected the myocardial work will be around minus 2,500 millimeter per cure. So the cardiac efficiency will be normally close to the 100%. And the vascular work close to the 0%. This is the one of the table that proposes the different indices of the myocardial work for male, from the female also. And we could collect our data regarding these differences that we have. So the most important for this type of the analyzing is actually the blood pressure and strain from the measure this indices. We have also some limitation. The pressure is surrogate for the fiber stress. We don't take the wall thickness also on the curvature that in account when we measure these indices. The segmental work is based actually of the strain, which is in relative numbers. Also, we have the result could be more accurately to consider myocardial work density. This limitation leads to the odd unit millimeter mercury for %. We call the resulting value for myocardial work index. Another results that could correlate from this myocardial work non-invasive indices assessment with systolic and diastolic function, which also coming from the Norris study. They are correlated very good with the systolic blood pressure regarding the global work index. with the ejection fraction positively correlated with the global work index. We have good correlation with the global work index and global radial strain and global longitudinal strain also. How is going with the patients with the aortic stenosis? This is one study which was published last year from, it's coming from Netherlands. They're looking about the patients with aortic stenosis. The myocardial work can be derived with echocardiography in patients with the severe aortic stenosis. And the indices provide that further insight of the left ventricle function in severe aortic stenosis. Myocardial work indices are independently correlated with the heart failure symptoms in patients with the severe aortic stenosis. This is our experience with myocardial work and looking about the regional pressure strain loop in the patient with the hypertensive hypertension. We have studied around 30% with the left ventricular hypertrophy and arterial hypertension, and during the stress that we look at about the increase after long in systemic vascular resistance in this group of the patients. Our conclusion in this study with the patients with the hypertension, left ventricular hypertrophy, we could compare more the normal blood pressure, and we have increased left ventricular systolic stiffness in regional myocardial work, which is much more arterial load at the rest. And they may have the diminished cardiac reserve when we increase the myocardial performance during the stress. There is another two very interesting study from the group of the Professor Erwan Donal. They're looking actually for the normal ranges of the myocardial work in the healthy subject. And another study is in the same group. When we look at the myocardial constructive work, we could correlate with the hypertrophic cardiomyopathy and impaired ejection fraction, and to predict the left ventricular fibrosis in this group of the study. This is one of the very last published study from the group of the Professor Smith. Like the cardiac power is one of the best predictor of the left ventricular ejection fraction, and to predict the risk marker of this group of the patient with the heart failure, based on the non-invasive assessment of the myocardial work and myocardial cardiac power output during the stress, comparable to the left ventricular ejection fraction. So I would like to conclude that the global work indices is potentially new technique that allow the better understanding and the relationship between the left ventricular remodeling, increasing the wall stress under different loading conditions. The non-invasive mitral myocardial work indices shows a good correlation with the traditional two-dimensional parameters of myocardial systolic function, myocardial strain also. We need more data to validate this marker for the wall thickness and the curvatures, like with the patient with the hypertrophic cardiomyopathy, dilated cardiomyopathy, which is more interesting group also of analyzing. The cardiac power integrates pressure, outer load, flow, and the heart rate. Could express the energy transfer from the left ventricle to the aorta. There is also need for the future testing and of the cardiac power method as prospective studies to before and can potentially replace ejection fraction as the measurement of the left ventricle systolic function. Thank you.
Thank you, Professor Christova. That was an excellent presentation for myocardial work. This is a novel method. There are not many years that it has been developed. And to be honest, we see a lot more publications, new publications in every cardiac pathology. First of all, we had patients for candidates for CRT. with LBBB, and we saw the value of myocardial work. Nowadays, we can see that it is useful in valvular heart diseases, in cardiomyopathies, in patients with preserved or reduced ejection fraction, as you showed to us. We have some questions. If it is better, first of all, if it is better to use segmental myocardial work rather than segmental strain to predict ischemic response or predict coronary artery disease?
I think so, because this is some of the studies shows that myocardial work is more sensitive marker from the ischemia than the global longitudinal strain when we measure all the segmental strain. Because some of the times that we don't have the good correlation with the good window for the analyzing of the strain, we could have them diminish the results of the myocardial work indices, actually.
And how reproducible is it from your practice?
I think depends of the group. For the patients for the CRT, I think it's 100% reproducible. For the patient for the another disease like aortic stenosis, hypertrophic cardiomyopathy, there is maybe 87 or 70%.
And of course, it depends on the imaging you have. If you have nice images, apical images of the patient, and create the bullseye of the strain, then you just do the timing, the event timing of the valves, and you create the pressure strain loop. It is highly reproducible and it is easy. And I think that in my opinion, that it will replace sometime strain and of course ejection fraction, because it actually shows the performance of the left ventricle by implementing the afterload.
Yes, we could expose the ejection fraction like there is many limitation and not the reproducibility as the result, but when we have the good images, we could usually use for our daily practice strain and the myocardial work as one of the very reproducible index.
Thank you very much again. We should move on to a great person and scientist, Dr. Stefanidis Alexandros. He will talk about cardio-oncology, how if 2D strain speckle tracking can guide the management of such patients, and what collaboration should we have with the oncologists. Dr. Stefanidis.
Okay. A very good morning from Athens to everyone. I can see such a good friends. Actually, I had an internal chat with Elif Sadeh from Ankara some minutes ago. Thank you. I will move on because I think that Giovanni Di Salvo is the next speaker, and I would like actually to focus to his presentation as well. So I need just 10 minutes, Kostas. Speckle tracking and cardio-oncology. If it is possible to guide our management. And I will start with a prelude. A prelude is practically one of my patients that before showing actually this video, I will give you what William Osler said in terms of the therapies that we are giving in medicine, that the person must recover twice from his disease and from the therapy as well. So the greatest thing in cardio-oncology is the necessity to cooperate with oncologists. We as cardiologists, we have to survive. Actually, we have to survive against this very difficult situation. From one side, we have the neoplasia, and from the other side, we have the therapies that we are giving that are most of the times deleterious for our heart. And I will show you very quickly one patient, I do remember him, with a case of cured neoplasia. He had peripheral edema, short of breath. He had a cured non-Hodgkin lymphoma 10 years ago, and he received for this chemo plus mantle field radiation, and you can appreciate now what happened to this poor heart. I actually think that everything inside this heart is affected by the therapy, and not actually because of his previous neoplasia. You can appreciate that the ejection fraction is low. You can see the valves that practically, you know, look, the calcium that it is accumulated in the mitral valve. And something that you have to appreciate as well is that we had a constrictive physiology in both ventricles. And you can see that in this MRI that shows us how the pericardium is practically moving with the left ventricle as well. And actually this poor man didn't have such a good prognosis after all this. And maybe he lost the game in this particular you know, stage of his neoplasia. The therapy of neoplasia and cardiotoxicity is something that we all know that, especially the last five years. It is very well appreciated, a lot of papers published, a lot of indices how to follow it up. Neoplasia can do arrhythmias, the therapies, arrhythmias, hypertension, myocardial ischemia, thrombosis, and of course, impaired myocardial contraction and relaxation. The most important medication that produces this is anthracycline. And the other one, which is used most of the times in breast cancer, is trastuzumab. We have to think about this medication as well. In terms of the diagnosis, the first thing that we have a lot of our means, a great armamentarium now, but you know, it is not easy to move on straight away to cardiac MR. And this is the reason actually that you said to me to speak about this topic. We can measure, of course, a 2D ejection fraction, volumes. We can do it with 3D, but we have a new tool, okay, let's say that we are using this for 10 years now, 10 to 15 years, but it is new in this particular, you know, topic. But there is a great question, why we have to do it? Great question, but some answers as well, because this cardiotoxicity is at the very beginning an irreversible problem for the heart. And one very important MRI study that actually is already 2 years ago, we can see that if we stop the anthracycline, we can prevent patients from having this evolution into terminal stage of heart failure. And on the other side, if we lose these patients, we might experience the irreversible stage of cardiotoxicity. And this is not good news as in the previous patient. Another means is maybe biochemical markers. But the problem is that even if we noticed some minor change in troponin values in patients that were treated with carvedilol and placebo, look what is happening in the volumes of these patients. No difference at all if we measure everything with 2D left ventricular ejection fraction. So the patients that received carvedilol and didn't have such an increased troponin in the biochemical, let's say, you know, measurement, we can see that they don't have different ejection fraction in comparison with the placebo patients. The Secure trial just finished. I learned that from Elif some minutes ago. I didn't have the time actually to change this this slide, but you know, these particular investigators tried to show if ejection fraction is something which is not better or which is not better than GLS. And the other question that can be answered after this trial is if we have to give cardioprotective therapy to these patients, do we really help them? A lot of different associations, a lot of different societies, a lot of different numbers in terms of the definition of cardiotoxicity. Look, even in the same, let's say, association and society, the ESC gives a cutoff for ejection fraction below 50%, the ECVI 53%. Okay, this is not a crucial thing. The crucial thing in these patients is the follow-up. I collected this slide. I showed this slide 17 years ago in one of my first congresses in Greece. showing that the correlation between the 3D, transthoracic 3D echo was an excellent correlation with CMR at that time. But you can see in the right side of the screen that most of the times we have negative values if we see the mean difference between the mean difference of volumes of 3D echo in comparison with the CMR. You can see even we use in quite recent studies, if we use different ventors, most of the times we get different numbers from CMR, most of the times lower than CMR volumes. From the same study, you can see that most of the times CMR measures dilated hearts, more dilated hearts in comparison with the ejection fraction of the 3D ejection fraction. Now, I would like you to focus on this slide. We would like to achieve this high precision with high accuracy. Let's say that this small spot is the 3D echo and this big spot is the measurement of CMR. The problem is that it is very, very difficult to achieve this in nature. The only thing that we can achieve, it is to improve, not actually the accuracy. It doesn't matter the accuracy. It doesn't matter the correlation from one technique to another. The highest problem, the severest problem is the precision of our measurements. So the better the standard deviation, the better the correlation, the better the means in order to follow up these patients. And the problem is that, let's say with trastuzumab, we have to call these patients again and again in order to follow them up. And you can understand that a lot of measurements means a lot of faults, a lot of problems if we have to refer these numbers to the oncologist. And maybe he would be, sometimes he thinks in order to stop this therapy, which is quite beneficial. So the standard deviation may kill. The bigger, the worse. And I will show you some examples. First example, let's say that we have chemotherapy patients and the ejection fraction 60 plus minus 8. If we give ramipril and an ejection fraction difference of 5% is enough in order to persuade us that we're doing something good. If you find this formula, all the statistics books in the last page have some formulas in order to estimate how many patients per group you need in order to prove something. So it doesn't matter how much is the mean value of this parameter, it matters the standard deviation. 8 standard deviation means 54 patients per group. With just an improvement in standard deviation, because we had a new machine, because we are better, since we started to decreasing the inter-observer and intra-observer variability, because we are getting better by following the guidelines, by gaining better experience. So just 2 degrees lowering of this number gives only 30 patients per group. The same is with the GLS. Most of the times GLS has shorter values, and you can see we need less patients, and if we improve ourselves, number 3 becomes 2, you can see that we only need 21 patients per group for 90% power for this particular study. Now, I will speak again for 3D echo because it is quite a very fancy technique. I like to do it in my daily practice, but you know, the problem is, look at these values. This is the left ventricular and diastolic volume with CMR and with 3D transthoracic echo. Look, however, this area of the good correlation. We have dilated hearts. And again, we have dilated hearts. So the bigger the heart, the greater the standard deviation as well. And I would say that do not even try to use 3D echo in patients with dilated heart in order to follow them up with cardiotoxicity. Another problem of 3D echo is the different ventors, and sometimes we do not get good standard deviation between these different ventors. And a very nice paper, actually, that it is Italian, I think, showed that even with different softwares, we get different standard deviations, mainly inter-observer standard deviations. And this is not good in order to follow up these patients. These particular investigators showed that the inter-observer variability of 3D echo is not very good in the area of 0.59 in order to follow up someone. And this is the conclusion of the study, that the variability of left ventricular ejection fraction computation with 3D echo could be a confounding factor, actually, and they suggest GLS. So imagine what will happen if we have different protocols, if we have different variables, such as 2D, semi or automatic 3D, some markers such as velocity of TR, and so on. Greater measurements, greater variability, greater difficult results. Now, I would like to use 2 or 3 studies in order to persuade you that 2D strain is better. In this particular study, they used anthracycline, and they confirmed that actually the heart at the very beginning is a little bit different in the patient that will develop cardiotoxicity. Look, the GLS of the good patients, let's say, of the ones that will not develop cardiotoxicity, is a little bit better than the baseline of the others. But look, the ejection fraction is the same. When these patients received 150 milligrams per square meter cumulative dose of anthracyclines, you can see that we have a huge difference, with 2D strain. In comparison, the ejection fraction didn't show any difference at all, just a trend. This particular investigator said that the area under the curve, when we use the first appointment of these patients in this particular cumulative dose, it is a very good one in order to follow them up with this particular technique. And this is the recommended borderline value, 17.5, in order to, let's say, to convince the oncologist that something is not good with this patient. We started having a developing problem. This study is another one that included another, very, I would say, flexible measurement, which is always the right ventricular strain. Look, if we include the GLS of the left ventricle plus the GLS of the right ventricle, of the free wall, just of the free wall, we increase the area under the curve, our diagnostic accuracy, to 0.91 in order to follow up these patients. And I would like to mention this study as well, even if it is a little bit older. It was a quite, for me, convincing that it is not only the GLS as a 2-dimensional variable, we might use torsion physiology as well. At least in this particular study, the investigators suggest that the twist just of the apex, the apical twist of the heart, might increase the diagnostic accuracy of the GLS of the left ventricle. And my conclusions after all this is that I would actually suggest to the audience of this particular excellent symposium that when you hold the transducer, please hold it with caution in all these patients. A minor decrease, a minor increase makes a huge difference. The traditional echo indices, unfortunately, are ready to be abandoned. It's a little bit provocative, but I would like if there are any possible questions after that. 3D echo and maybe 3D speckle tracking included, until further notice, I would say, is not so convincing for these patients today. The 2D speckle tracking is considered as the best and flexible tool, and fast, actually. Guidelines and recommendations have been written in order to be read by all of us, experts included. I have to thank you for your attention.
Dr. Stefanidis, we thank you for covering this topic. To be honest, a lot of people are troubled of how to manage such patients, and I think that cardiologists should be in close collaboration with oncologists and define the follow-up and the treatment of these patients. So we have data for all these treatments. Do we have data about radio treatments with radiation for the muscle?
Kostas, what I believe as a general comment that what is in science, actually, I wouldn't say only in science, in nature, in general, what is really distinguishes the human race, it is that we build, let's say, our cathedrals and we send spaceships in the space because we are able to cooperate. And what I think is that this great topic can be, let's say, ameliorated, can be improved by the good collaboration between oncologists and cardiologists. Let's say one evolutionary scientist, anthropologist, said that the survival of the friendliest is the means in order to survive in nature. So what I think, we have the tools. The problem now is to estimate everything, to assess everything, and to recognize what is the tool which is flexible. I realized from the excellent speech of Professor Elif from Turkey that she showed that the result of the SECURE trial gave just 5% difference in these patients in ejection fraction in order to understand that the heart started to deteriorate. Let's say that I'm a little bit experienced. I wouldn't say that I'm a good echocardiographer. Let's say that I'm doing this for 20 years in a daily practice. I cannot achieve such a good reproducibility with my hands. So we need a new equipment, a new tool, something in order to improve our armamentarium, Kostas.
The ejection fraction?
Look, unfortunately, the ejection fraction has to be abandoned, especially in these patients.
Also 3D?
And this is the problem. I have a new machine. I try to improve my, my reproducibility. I would say that sometimes some patients do not have a good acoustic window. They cannot hold their breath for some seconds. The acoustic window is not good. They are sometimes having problems. Let's say the problem with the mastectomy in these patients. Sometimes they feel the pain. It is by the way of thinking something promising, but not a current reality for these particular patients. A little bit provocative, I know.
Here is one question to Professor Stefanidis. Do you respect the protocol for follow-up the patient who is receiving Herceptin target therapy, following the patient every 3 months by the same cardiologist on the same echo machine?
Yeah. This is a very difficult question to be answered. It would be a fantastic world if everyone had the same hand and the same, let's say, experience. It is better to use a good machine with the same cardiologist, and at least one patient that has this evolving problem needs time. I wouldn't say that I will lower my practice to less than 20 minutes per patient, because I have experienced a lot of mistakes when you want just to take 2 apical views and to say, okay, I have your GLS, I will measure it, okay. You can leave and I will give you the number. And after that, when I measure it offline, I can understand that this patient actually lowered the GLS 2%, even if I can see a good ejection fraction. So every patient needs 20 minutes time in order, at least 20 minutes time in order to say that we scanned him correctly. We scanned him in a reproducible way. And the protocols are there, have been already provided from one journal, the European Journal of Heart Failure. It depends on the medication. It depends on the stage of the patient. All the assessments are there and waiting for us, actually.
We have 2 more questions. One general, which vendor do we recommend? I would say that every company has its advantages, but I want just to mention that myocardial work is for GE exclusively at the moment. I guess that in the future, other companies as well will produce myocardial work. And one last question, Dr. Stefanidis. If no significant drop in ejection fraction, but a reduction of GLS more than 5%, do you say to discontinue chemotherapy?
Very good question, actually. This is the conclusion of my presentation.
And start heart failure medication.
Yeah. This actually has been already answered by the Sukur trial. It was released in the 2nd of February. You can find it. I didn't read it actually. But you know, 5% absolute value, a lowering of 5% of GLS is a very, very big difference. So we have to respect that. We have to see again, of course, the imaging. If it is an imaging that it was taken in some seconds, I'm going to respect it. But if the imaging is clear and the GLS is 5%, this is actually a disaster. The patient has to start a decongestive heart failure therapy.
From my experience, I don't remember any patient that had a reduction of 5% of GLS without seeing
an absolute value of the percent that, let's say, because
an absolute value.
An absolute value is a huge one.
It's a huge one.
Yes.
And I think it correlates well with the reduction of the ejection fraction as well.
Yeah. It can be evident, I think, even with the traditional indices. Even if you don't have to do an echo actually to them, you know, something happens. Something happens.
You have the clinical presentation.
They open the door and they have tachycardia and they are short of breath at that point. 5% is huge.
Thank you very much, Dr. Stefanidis.
Very welcome. Very good.
Thank you. And I would like to continue with the next speaker. It's my very big honor to introduce Professor Giovanni Di Salvo. He is very well known. He is the part of the EAC new board, and it's very good, my friend. Giovanni, welcome to our meeting. The next topic that you will introduce is very new study that you implement in the congenital heart disease patient. Actually, this is the blood flow speckle tracking, which is more important to recognize some of the mechanics of the ventricles.
Thank you very much, Casimira. Thank you very much, Kostas, for this kind invitation to this excellent meeting. So it's my pleasure to share with you our experience with this new technique in congenital heart disease. Leonardo da Vinci was the first one to understand the universal concept of vortex formation. And he was the first to understand without any imaging modalities that vortex formation have a role also inside the human body and inside the heart. We know that it's very important for us to study blood flow, and what we do in our current clinical practice is to use Doppler and Doppler-derived technique. Unfortunately, Doppler is limited by angle dependency and also by aliasing, so we cannot read on color Doppler some velocity when they are too high. And the other issue is that with Doppler, we can only assess laminar flow and turbulent flow, but in the human body, blood flow exists in 3 states: laminar, turbulent, and vortex. And the laminar mitral flow is converted in vortices in the left ventricle during diastole. So it's a common phenomenon that we are currently missing with the current technique. Vortex are indeed very important because they can prevent excessive velocity gradient and reduce the impact on the left ventricular wall. Vortex are a way to preserve kinetic energy and to increase cardiac efficiency by maintaining the momentum. So what is a vortex? A vortex is a fluid structure with a circular or swirling motion spinning around a virtual central axis. And this structure is able to entertain more fluid at a decreased pressure. So with a vortex, we can transport more mass than a straight jet can do. And with vortex, we can preserve kinetic energy and reduce LV filling pressure. That's why nature preserved this structure everywhere, not only in the human being. And the heart is structured to create vortex, particularly the mitral valve as a morphology structured to create vortex because of the eccentric position of the mitral valve orifice and the asymmetry between the leaflets. We know that in French authors describe the mitral valve as the grand valve for the anterior mitral valve leaflet and the petite valve for the posterior mitral valve leaflet, highlighting the asymmetry of the two leaflets. And this asymmetry is not just by chance, but there is a reason. And one of the reasons is to create vortex, because vortex inside the heart preserve energy. And so we have a better efficiency in cardiac mechanics. And vortex are created during diastole, mostly during diastasis. We can study vortex nowadays. We can study by using cardiac MRI, but as you know, cardiac MRI is not widely available and is more costly. And also we can use it very well by echo. And we have different approaches nowadays. We can use contrast agents, or we can use approaches that combine Doppler and strain, or we can use the blood flow speckle tracking. In few words, we will use the same approach that we are currently using to study the myocardium, so the speckle tracking applied to myocardium, but this time we will apply this software to study the flow. And this approach does not require any injection of contrast agent, so it's very easy to be used. In this video, you can see what is done. Basically, we use the same approach as speckle tracking. So on the image, we impose some kernel, and in this kernel, we follow the speckle generated by blood flow using the algorithm of the best match approach. Of course, while myocardium has a low velocity, centimeters per second, blood flow has higher velocity, meters per second. So this implies that we need very high rate transducers. And that's why we need very high frame rate, over 600 frames per second. And this ultra high frame rate acquisition is nowadays obtained by using a plane wave imaging technique, which at the current status can only be achieved by using the pediatric probe or the transesophageal echocardiographic probe. And this approach has been validated also in using in vitro model. And nowadays we can use it in we can test it in the clinical practice. This is a case of blood flow imaging in a normal heart. And as you can see here in the parasternal long axis view, you can see the vortex formation anteriorly to the anterior leaflet of the mitral valve. And you can study virtually everywhere the blood flow, not only for the left ventricle, not only from parasternal view, but also from apical views. And you can study also the vortex formation and the fluid dynamics inside the right ventricle and the aortic arch. We use it in this approach in several congenital heart disease, starting from the simplest one, the ventricular septal defect. And here you can see the blood flow going through the VSD and created this turbulent flow inside the right ventricle. The same we can see from the apical views. Again, we can see the flow going through the VSD and disturbing the normal fluidodynamics into the right ventricle. So we have additional information because, of course, we can see the shunting lesion also by using color Doppler. But now we know that is not only a question of shunting lesion, it's also a question of disturbing, altering the normal fluidodynamics in the right ventricle in this case. And again, this is the same patient who underwent VSD closure. So this is the normal heart with the nice vortex formation in front of the anterior leaflet of the mitral valve right here. And this is a patient who underwent VSD closure. You can recognize here the patch. But here, if you can see, the vortex is still abnormal. And you also can see that the flow is going through the aortic valve, but is hitting the patch. So even if we completely cured the shunt lesion, still there is some abnormalities in the fluidodynamics because the flow is hitting the patch. And this is an information that we cannot have by using conventional color Doppler. And from simple VSD to more complex congenital heart disease like atrioventricular septal defect. This is a complex congenital heart disease where we have a atrial septal defect type ostium primum, common atrioventricular junction, and VSD of the inlet portion. So the left valve is not any longer a mitral valve, so there is no the asymmetry that we described before, but is a left heavy valve with completely different characteristics. There is a bridging leaflet, superior bridging leaflet, inferior bridging leaflet, and mural leaflet. And as you can see, the flow going through the left heavy valve into the left ventricle is not doing the vortex in the expected position, but we have a vortex at the apex of the left ventricle. And this is why we, in this patient, we have a rounded apex, because the fluidodynamics affects also the morphology of the cardiac chamber. And we know from fetal heart that the fluidodynamics can stimulate the growth of cardiac chambers. Again, this is the atrioventricular septal defect, and we can apply this technique and we can clearly see how the fluidodynamics inside the heart is completely different from a normal heart. Here, it's at the level of the atrial shunting, and you can see how the turbulence spreading around the left atrium to the right atrium and across the common junction. So we don't have the laminar flow that we expect before the mitral valve, but we have to remember this is not a mitral valve. And fluidodynamics has been very well studied in the aortic arch using cardiac MRI, and especially in bicuspid aortic patients. And now we can do this bedside without using any contrast agent, using this technique. And this is an example of a normal aortic arch where you can see the laminar flow and a small vortex formation at the level of the isthmus. And of course, we use such a technique also in patients with aortic coarctation. As you all know, aortic coarctation is narrowing in most of the cases at the level of the isthmus of the aortic arch. But this narrowing is the top of the iceberg because all the aortic tree is stiffer than the normal heart. And you can see here, this is a patient with aortic coarctation, how the flow is different compared to the normal heart. And you can see here turbulent flow at the level of the isthmus and not a vortex formation. And this is a stop frame again, comparing normal systole and coarctation. And also we have so-called pseudo-coarctation. It means that there is no real coarctation, but the aortic arch is severely angulated, but without a gradient. So if we use color Doppler, we will see color flow acceleration, and here we will measure a velocity above 2 meters per second. But if we use the Speckle tracking blood flow technique, we can see a vortex here, a normal vortex. So this is suggesting us that the flow is normal, and the aliasing that we see here, the color, is not because there is a stenosis, but just because there is a huge vortex related to the severely acute angulation of this aortic arch. but this is not a coarctation. And also, this is a case of patient with Marfan disease and bicuspid aortic valve, and you can see how the flow is hitting the anterior wall, the anterior face of the ascending aorta. And this is probably a trigger for ascending aortic dilatation. Again, we can see this very easily just doing a simple echo, let's say, but there is nothing like a simple echo, and a bedside patient in a very inexpensive way without using any contrast agent. This is another patient with congenital heart disease, cohort 3 atriatum. So you can normally, in the normal heart, there is a vortex formation in the atrium just below the pulmonary veins. And then just above the mitral valve, we have laminar flow. Here, there is a cohort 3 atriatum, so there is a narrowing here. And you can see how the flow is turbulent here, and there is no laminar flow at the level of the mitral valve. So it's not only a question of stenosis, but also the fluidodynamic inside the heart is completely abnormal. And this makes the cardiac mechanics less efficient than in the normal heart. This is a patient with hypertrophic cardiomyopathy with some gradient in the LVOT as demonstrated by the Doppler trace with the classic shape of the sword. And again, you can see this is very fast heart rate, so probably you cannot see the vortex, but you will see that the vortex that we should expect here in front of the anterior mitral valve leaflet is more toward the apex and is smaller, less rounded, more elliptic. So this heart is not able to preserve energy in an efficient way. So the cardiac mechanics is abnormal and diastole is less efficient in this patient. What about prosthetic valve? This is a pediatric patient with a biological prosthetic valve in mitral position. And if this was a normal mitral valve, we should expect here a vortex, but we don't have any vortex. So again, no gradient, good working prosthetic valve, but less efficient. We don't have vortex. So this heart is not saving any energy for the LV filling. And this is the same this is another patient actually, where the prosthetic valve has been, since he was very small, the prosthetic valve has been allocated not at the level of the mitral valve annulus, but inside the atrium, because there was no prosthetic valve small enough to sit into this annulus. So we had to sit the prosthetic valve into the atrium. And you can see how the fluid dynamics is abnormal. So again, no gradient, but less efficient cardiac fluidodynamics. And this is an example of how a nice study from the Norway group, where they demonstrated that prosthetic valve, they have a less efficient way of fluidodynamics because they cannot reproduce the vortex in the normal position. This is a complex case on the other side of congenital heart disease. Simple transposition of the great artery, ventricular septal defect, and pulmonary stenosis, or what we believe is a pulmonary stenosis. And this is very important because if this patient has a true pulmonary stenosis, we have to go for a different kind of repair, more complex surgery at a later stage. If this is not a real pulmonary stenosis, we have to do another kind of surgery with another timing. And it's not easy to differentiate because since there is a VSD, there is increased flow across this valve. So the gradient that we can get by using conventional Doppler can be just fluido-related. There is volume overload across this pulmonary valve, so that's why we get gradient. Using a blood flow study for the Speckle tracking, we can see that the flow across the pulmonary valve is laminar flow. So there is no real stenosis, it's just increased volume that is crossing the valve. And these may have important clinical implication in management of such patients. But this technique can be used not only in pediatric patients, but also in the fetal heart. This is another a nice example from the Toronto group recently published on the American Society of Echo, where they used this technique in the fetal heart to study the most difficult part to understand the fetal heart, the aortic arch during the fetal life, and also the heart. So this technique can be applied also to a very small heart like the fetal heart. And with this, I come to my conclusion, that more than conclusion, of the possible future direction of the study of the non-invasive study of fluidodynamics, better understanding of the intracardiac fluidodynamics, better understanding of cardiac mechanics, because we saw that no gradient, normal velocity doesn't mean normal fluidodynamics, and does mean that also the cardiac mechanics is less efficient. So with this technique, we can identify inefficient ventricular mechanics and flow with regional energy losses. We can better understand diastole, and in the future, we hope we can identify a better way to quantify blood flow without the limitation of standard Doppler. Thank you very much for your attention.
Thank you so much, Professor Di Salvo. Very interesting presentation and a very uncommon disease. I would like to ask you something. Because the blood flow speckle tracking is only visible on the machine, we cannot measure any of the particles on the vortices indices that it's possible some of the tools who implemented the mechanics on the inside on the ventricle. How do you think will be possible to correlate some of the data from especially for the measure the systolic and the diastolic function of the chamber of the ventricle to the vortices?
Yeah, thank you very much, Casimira, for this question. By ECHO, we have a greater armamentarium already to study fluidodynamics. So we have different softwares. This one, blood flow speckle tracking, is as it is now, we can only see the flow patterns. So what I've done so far in my experience is to describe different patterns. But at the moment, there is no dedicated software to measure the vortex, the energy, and so on. But other approaches by other vendors combining strain and combining color Doppler, they can actually measure the vortex area, the energy loss, and so on. I probably think that the best way is to combine these two approaches, because I think we should try to find a way to get rid of the Doppler limitation. So if we can quantify the blood flow speckle tracking without using any Doppler assumption, this is probably a game changer, in my opinion.
Okay, here is one question from the audience. Do you think that vortex in mitral valve clipping would affect the physiological fluid dynamics?
Well, for sure, if we do the mitral valve clipping, and we will have different fluidodynamics. I have a few examples. It would be nice to do a study. And probably the future will be not only to correct the gradients, but also to preserve the best possible fluidodynamics, because the heart has to save energy to last longer. So if we have not efficient fluidodynamics, the heart to work has to consume more energy, and this is probably not the optimal way. So there is still a lot of room for improvement.
One more question from the audience, Professor. If there is any study that correlates NT-proBNP with abnormal vortexes, do you have any?
No, not that I'm aware. But again, I mean, this is a very new technique. And as I said, this technique can be used as it is now, only with the pediatric probe or the transesophageal probe. Yes, there is a room to implement. It would be also nice, you know, to combine the blood flow speckle tracking with myocardial work to see if despite normal gradient, normal velocity, that heart will use more energy. So this can be also room for a lot of research.
And I have also a query. Can we demonstrate a PFO?
Yeah, you can.
We can use it instead of bubble study, for example?
Yes.
With the salva maneuver and all this?
Yes, you can do it. Of course, as this is a 2D based technique, so you need to have a good 2D image quality. Yeah. As for all the speckle tracking based technique, if the 2D speckle tracking quality is not good, then you cannot see anything. That's the limitation.
Okay, and let's see if we can answer one more question, and then we can go to break, coffee break. We have a question about the use of 3D in congenital heart diseases. It's not on your topic, but
it's okay.
We have a participant asking if it is just nice pictures or should we use 3D?
So I can tell you my clinical experience. I use 3D mostly for morphology, to understand better the morphology and to give additional details to the cardiac surgeon. Being very honest, I always do my diagnosis starting from 2D. Then I go to 3D if we want to give additional morphological information to the surgeon. This is very helpful, to be honest, when you study atrioventricular septal defect, to study the common junction, the common AV valve. You can get very nice picture and you can give additional information to the surgeon. The same for the mitral valve or for complex VSD. But again, I always do my diagnosis in 2D echo.
Okay, Professor Christova, should we have a coffee break as is it scheduled? Professor Di Salvo, thank you very much for this presentation.
Thank you very much for the invitation.
Nice topic, very interesting. So we are a bit late, but I think that we can have 10 minutes break and come back in 12:20.
Yes, to continue as the program. Yes. 12:30.
See you all in 10 minutes. Thank you very much.
Във времена на несигурност се обръщаме към най-сигурното нещо, което съществува. Науката. Науката може да пребори заболяванията, да открива лечения и да побеждава пандемии. Правила го е преди, ще го направи отново. Защото когато се срещне с ново предизвикателство, науката не се отказва, тя атакува и задава въпроси, докато не намери отговорите. Това е силата на науката. Затова даваме тласък точно на науката и я развиваме. Нашите проучвания, експерти и ресурси, всички усилия са насочени към развитието на потенциални терапии и ваксини. Другите компании и академични институции правят същото. Цялата световна научна общност работи заедно, за да се справи с предизвикателствата и всички ние използваме науката, за да помогнем това да се случи. Защото ако науката спечели, печелим всички.